everything done? Okay. So, a very good evening and a warm welcome. In Chennai, I can't tell warm welcome. It's very, it's little drizzling and rainy today. I think it's one of the happiest moment for Chennaites. After a long time, we are seeing some water droplets. Anyways, so we are here for the session on occlusion digital way. So today's moderator is Dr. Arka Swarnakar, a young dynamic prosthodontist, graduated in 2016 from Kotwal Dental College, and he's the presently he's a reader at the same dental college department of prosthodontics. He is an executive committee member of Indian Prosthodontic Society West Bengal State Branch, associate editor for Journal of Orofacial Rehabilitation, member of the reviewer board of the same of our national journal JIPS, and he is a professional speaker and an author for various publications on his name. Dr. Arka, the entire program is yours.
Thank you very much, sir. Thank you, Dr. Sangeet Kedireddy, sir. Good evening, everyone. And it's an honor to moderate this program named the Digital Occlusion and Analysis, hosted by the very dynamic state branch of Telangana and Andhra Pradesh. Today, I'll be introducing to you the 4 expert panels, and here we are. Our first expert panel is Dr. Santosh Singote. He has done his BDS in 2000 from BVDC Pune. He has completed his MDS from Naya Dental College, Mumbai in 2003. He is a fellow of ISOI. He is also a diplomat of WCOI. He is the immediate past president of IPS Pune branch. He is currently the professor and PG guide of Department of Prosthodontics, VPDC Sangli. He's an exclusive prosthodontic practice. He's doing an exclusive prosthodontic practice for last 17 years with an emphasis on implants and full mouth rehab. We welcome you, sir. A second panelist in our expert panel this evening is Dr. Kamal Singhli, who is currently working as the professor and head of the Department of Prosthodontics in DY Patil Dental School, Lohegaon, Pune. She has tremendous interest in research work, which includes prosthodontics and geriatric dentistry. She's an expert in a discipline of dental sciences, and a few years ago, she has begun a journey towards becoming a scholarly teacher and scholarship of teaching and learning. To enable this, she has completed her fellowship from FIMER, that is Foundation of Advancement of International Medical Education and Research from GSMC Regional Institute, Mumbai in 2017. Ma'am, we welcome you in today's program. Next panelist in our expert panel is Dr. Vijay Singh More. He has completed his BDS from VP Dental College, Pune in 1998. He has completed his MDS from GDCH Aurangabad in 2002. He is DEU in implantology from France in 2012. He is currently the professor of the Department of Prosthodontics in BVP Dental College, Pune. He is the program head of CIIOFI India. He is also the director of Center D Implant in Pune. Sir, we welcome you in today's program.
Thank you. Thank you, Dr.
And last but not the least, our final panelist for today's evening is Dr. Parmeet Banga. He is professor in prosthodontics in YMT Dental College, Navi Mumbai. He is a mentor in the Implant Fellowship, MUHS. He is the Executive Council member of Indian Prosthodontic Society. He is the treasurer of IPS Mumbai branch. He is also the executive member of IDM Mumbai branch. And he is known for his guest speaker performances in specialty conferences, PG conventions, CDE programs, etc. Sir, we welcome you. And
thank you, Arka.
I would request Dr. Parmeet Banga sir to introduce our speaker for today's evening. Thank you.
Thank you, Dr. Arka. It's indeed a pleasure to be part of this international summit organized by our very good friend, Dr. Jangara Hari and Dr. Sanket Keti Reddy. It's a pleasure to introduce none other than today's speaker. I mean, who doesn't know Dr. Peter Bausch? Born in 1963, trained as an export trader of 1984-86, study of chemistry in 1986 to 87, study of food technology in 1987 to 89 at the Technical University of Munich, then personally liable partner at the Dr. John Bean Bausch GmbH company since 1990, responsible for the product development and intensive research in the field of coating paper and film. This coating paper and film is there in practice in day-to-day life of occlusion, adjustment, left, right, center, up, implants, fixed, and removal partial denture. There cannot be any person in this world who doesn't know Mr. Peter Bausch, who has been inventor for this articulating papers and the coating papers, which are used widely in the field of interocclusal dentistry. The topic, sir, will be covering today is occlusion, the state of art. Summary will be interaction between mandibular joint and spine in the state of art. Concepts of occlusion, influence of occlusion, tools for visualizing occlusion, basic technique for establishing a centric relation of mandible, the state of art, how important is occlusion, and summary of clinical research. Demonstration of some of the new digital occlusal sensor Oclusense based on some patient cases. So the country of India welcomes you to speak on board and enlighten the bright minds which are there to listen to you. We welcome you wholeheartedly on behalf of IPS and IPS Telangana branch.
Yeah, thank you to everybody, especially you, for this very beautiful introduction. And it's a great honor for me today to speak to this group. So welcome to our to my presentation, and good evening to India. And today I give you just a teaser. So my topic is still occlusion diagnostic, what kind of method we have for occlusion control. And finally, we'll end up with digital occlusal diagnostic. But before I start, I give you just a little introduction in our company. And the Bausch company has been founded from my grandfather and my father already in 1953. And at this time, the occlusion was not a big topic in dentistry. And my father, actually, he was the inventor of a new articulating paper. Our company still is based in Cologne. And everybody who wants to join the IDS this month is, of course, very welcome to visit our booth during the IDS, and probably also has a chance to visit our company in Cologne. In 1953, my father started with the first articulating paper with progressive color transfer. And he was like Steve Jobs or like Microsoft. He started in a garage, and this was the first machine. And this is how it started. And this is just a view. This was an IDS in 1962. And I just give you a little teaser. So this is our new headquarters and education center in Cologne, and you're very welcome to visit our place. So this was just a teaser to our new company and our new educational center. And today, I want to give you a little bit more information about our new product, digital occlusion with Oclusense. We have developed this product in 2017, and we have been first showing it on the IDS in 2019. And I have chosen this title, Hidden Occlusion Interferences. So this information, or this machine gives us some new information about occlusal habits, which we have not seen before. But before I go more deeper in this topic, so see, for example, this is also a record, how it looks like. So this is what you see out of the machine. This is a movement of the mandible. You see different contacts coming up and down, going down, and you see different columns in different colors. So I will give you later some more detailed information about this, but before, I would like to start with some basic diagnostic things, and this is our program for today. So we have first the anamnesis, intraoral exam, functional analysis in an articulator with the mini-rex system, occlusion test material, of course, and final, last but not least, Oclusense. And when we go to anamnesis or intraoral exam, what is important? Now, we can do diagnostic, occlusal diagnostics, and the thing is, you have to make an interview as a dentist. You have to ask your patient, and you have to consider what is your problem with the patient. What do you see suffering from pain or what else? And this is what probably the problem is, what the doctor wants and what the patient wants. And you have to tell them this is possible or not possible. Anyway, important questions are about general diseases. Does he have any problems, postural habits? Does he have pain in other parts of the body? Does your patient have had previous treatments? Does he take any medications? How are his sleep patterns or habits, allergies, job positions, and so on? And this questionnaire is very important to give you a better image. In Germany, we use we also have here, we ask, is your pain tolerable or it's extremely pain? So we screen our patients. So this is some basic tools which can be very, very helpful for the treatment of your patient. And especially, we are not looking for cavities carriers. When we work with occlusion, we have to look for tooth hypersensitivity. Do we have any class 5 cavities, say non-carriers, cervical lesions, lingual and palaticide, periodontitis or an individual teeth, broken teeth, cavities, crowns, tooth wear, misshaped teeth, relation of teeth to each other, also say previously also non-treatments, range of motions of the mandible, and probably also bite impressions in the tongue or sheath. These are all signs. And so our understanding of occlusion or the masticatory system is we have a very, very complex, if you look here, occlusal changes can be prosthetics, restorative dentistry, surgery, orthodontic treatment is a big factor, periodontology, postural movement, dental oral diseases, also psychosomatic diseases, stress, conflicts, the family can be has an influence, bruxism could have an influence, and this is the outcome. So we call it TMD or craniomandibular dysfunction, can be headache, TMG complaints, difficulties in swelling, tinnitus, clenching, grinding of teeth, tension in the neck muscles, back pain, and also different, say we could say adaptation of the posture of the body or say positions which are more comfortable. You think they are more comfortable. But we have to understand this as a very complex biological system. And if you have patients complaining about pain, we need probably a little bit more specific. And finally, we have also to focus on the muscles, which are playing a major role in the system. And if we have any diseases on the muscles, we can consider muscle overload. Is it a problem of the adaptation, tension in the muscles, different flexor movements, or even also other conditions like hypertrism? Is there a problem with this, with the hormones of the patient? So this can be all reasons why muscles can hurt. The chewing or coordination of chewing and swallowing movements is a very complex neuromotoric process in the masticatory system. So we always have to consider this. And we have to consider also the movement of the different muscles. We have to consider the structure of our joints. And we also have to consider our biomechanic system. This is like a transmission, our joints especially. And this is the only joint in the entire human body which can move in 4 directions. And this makes things more complex. Neuromuscular influence is also very, very complex. And our brain is our computer. So if we have an influence from occlusion, we have this, we call it afferent, which go right into here, and then they can give a signal back and probably have a little problem here. Immediately you start adapting to a new position. In German, we say a word Schonhalter, means you go into positions which you think they're better for me. Maybe they're better for you, but maybe on the long term, you might have a problem that these positions can also have an influence on other structures. And if you take a close look in the periodontal ligament, we are faced with different biological structures and receptors. What is important? First, it's very important to consider our periodontal mechanoreceptors. We have our RA, rapidly adapting sensors, and we have slow adapting mechanoreceptors. RA receptors are very, very sensitive. That is the reason if you have a little hair between your teeth, especially between your anterior teeth, you can feel it. So the RA receptors are very, very sensitive. That means if you make any changes here, your body reacts very, very sensitive. The slow adapting receptors, they are designed to take more forces, to measure bite forces. Inside our periodontal ligament, we have a little natural suspension, which calls the Sharpesian fibers. This is a natural compensation. So in the literature, you find different meanings. So occlusal interference between 10 and 20 microns can be compensated by the natural suspensions. And well, this is a little animation. So when you have a certain pressure on the tooth, so you see this tooth will a little bit intrude, and the contacts here and here are probably a little bit more balanced. But imagine if you have an implant, for example, this system is not present anymore, so you have no compensation. And therefore, occlusion on implants is also a very special case which had to be considered. So if we have to deal with occlusal interferences and the sensors are recognizing, oh, I have a high spot, automatically you want to adapt this position and you try to move your mandible into a different position, which you think is more comfortable for me. So here's a movement without, and here's a movement with the interfering contact. And if you have such, say, jaw tracking machines, you can easily, say, research or say look for such traces or such movement traces. And adaptation is a natural process. It's a natural process of all biological systems. So without adaptation, we all would be dead. The capacity of adaptation is limited and very individual. You have patients, they can take much more, say, treatments. And you have patients which are very, very sensitive. You only make a little restorations, a little filling, a little composite restorations. They have a big problem with occlusion. And you can imagine over the years, you have an input. You get one treatment, another one, orthodontic treatment, and until your capacity is overloaded. And then your patients may run into a big problem. And then again, you are here and here. So what tools we can use to help those patients to avoid, say, an overflooding of our adaptation process? And of course, we have a lot of tools. We just give you a teaser because it is a full day course. Palpation of muscles. Palpation is very important, and the muscles give you a lot of information if they are painful, yes or no. And we can use it also during a splint therapy, and you can also see if the patient feels better before or after the palpation. Usually we focus on the big muscles, temporalis, masseter, because they are easy to find. The other muscles, you need some more experience, and never try to push hard. This is something I can really recommend, and it takes some time to learn it. Another very nice test is a manual test. And this is also a teaser. We call it diagnostic specific intervention. And this test has been developed by two professors. So one professor is Professor Dr. Axel Buhmann, and Gerd Goldandwer, he's a physiotherapist. And they have been, teaching a whole concept of different manual techniques. And a good friend of mine, a very good dentist, has to reduce this concept to 6 basic, say, tools or basic examinations, which you can use for every patient. And if you get a little bit training in this technique, you get a very nice basic test or basic result anamnesis if my patient is suffering from pain, yes or no. And the first test is, say, unequal condyle movement. You just check, is my patient moving the mandible equal or not equal? Always asking, do we have pain when you move your mandible? Another test is, do you have any limitations in opening your mouth? At least 2 fingers or 3 fingers should go in. Do we have any noises when I move my mandible? This is a test. We are provoking the structure. So when you go behind your patient, and you take the mandible and push it left or right, first in a dorsal direction, and then you put it in a lateral, dorsal, cranial direction. So this is provoking the capsular of the joint. And if the patient says, I'm in pain, it doesn't feel very nice, so this is a sign that he probably has a capsulitis. And we do it, say, left and right. And finally, we also recommend to do an isometric muscle test. So the patient is biting on 2 cotton rolls for 30 seconds as hard as he can. And the second test is he is trying to push the mandible into your hands and also tries to hold this position 30 seconds. Also ask him, do you get muscle pain? Are you able to do it 30 seconds? Yes or no? These are just simple tools everybody can use in this daily practice. Finally, we have functional analysis in the articulator, and then we use a very nice tool which has been invented from Professor Sanata from Sao Paulo in Brazil. And of course, we have to consider some, say, basic, say, reference positions or planes, like the Frankfurter horizontal plane, the Kamper plane, and the occlusal plane. And the thing is, the goal is to transfer this information into an articulator to simulate the occlusion, the movement of my patient in a full or at least semi-adjustable articulator. And this is a basic question in dentistry. So in the past, there's a lot of we have been asking what is the correct position of the mandible, and the older ones maybe here, they know in the past we have been trying to push the mandible to the most retruded position, as far as most retruded as you can. The question is this a very physiologic position, yes or no? And we think, considering all these definitions you find in the lecture books from many, say, high sophisticated professors, central regulation is a position which has this very nice definition from Bob Lee, one of the inventor of Panadent articulators. They say this position of the mandible to the maxilla with the intra-articular disc in place when the head of the condyle is against the most superior part of the distal facing incline of the glenoid fossa. This can be paraphrased at uppermost or foremost. So this is the definition. But in reality, we have this. Over 90% of your patients are in a neuromuscular position of the condyles. And this is a neuromuscular adapted position with complete occlusion in most cases. And most of your patients are okay with this position. As long as they don't have pain, don't touch them. And we give a name to this position, we call it habitual maximum intercuspation. It may be a light deviation from the real centric position, but we can call this position as a physiologic centric. So stay with this. When the patient has no pain, don't touch it. When we create an artificial occlusal high spot with a restoration of filling, of course, our neuromuscular system, our neuromuscular adaptation is starting, and somehow the patient is shifting his mandible in a new position. And this position can be okay as a new neuromuscular adaptation, or your patient is starting from pain. You get this, headache, hand muscles, TMD. And then we have to consider how we can find a therapeutic position for this patient. And there are a lot of tools. We can use a jig splint like the mini rec. We can use an aqualizer, it's a hydrostatic splint, or you can also use other techniques. So there are the manual techniques like the Dawson technique. There are many things. I would like to give you a little bit more information about this mini rec system, because I think it's a very, very good tool, and it's simple to use, and it's not very expensive. And what you need is a Facebook, at least a full or a semi-adjustable articulator, a mini rec, and a bite registration wax plate. And this animation is just showing you the basic, say, how we can use or take a Facebook image, Facebook registration. So we use BioArt articulators sometimes. There's a brand from Brazil, which is a very good and, say, very reasonable price, good articulator. And this is very simple. It's not rocket science to take a facial registration with this articulator. And then we put our bite registration, and then we have our, say, correct position in the articulator. And here we can simulate all movements of the patient. And we also should be able to adjust the basic, let's say, Bennett angle. Now here you see it in the live, it's a real patient. So see, it's very, very simple to use such a system. So this was a course I have done with Professor Sanata last year in Portugal. Well, and as you can see, it takes probably 5 minutes of your time to get available information about the position of your patient, which you can transfer into the articulator. And by this, you can also avoid a lot of occlusal grinding afterwards if you have done this work before. So this helps you to save 90% of the grindings, especially when you do ceramic restorations. So occlusal adjustment should be reduced to a minimum. So this is the way how this works. It's a little plastic device. You can fix it with putty silicone or other, say, materials. We use an occlusion test spray, and then we can, say, see the traces of the mandible movements. And finally, so this is just another animation. Yeah. This is very familiar to us because if you do full dentures, so we use so-called the Gothic arch or a Giese arc, where they have different names in different countries. But this is a typical Gothic arch bite registration, which we know from Gerber, Giese, McHorris. And simply you can record the mandible movements. And it's also a very nice tool because if we have an occlusal class 2 patient, so we just turn it around. And we also can check the movement of the mandible of an occlusal class 2 patient very simply. Now you see a class 1 patient. This is fine. So you have enough range of motion to the anterior direction. On class 2. So this will not work this way, but if you turn this device, we can easily check this motion of ranges of the mandible. And here's another animation on the patient. You can also trim the system down to the patient's needs so that it maybe fit better. You see here it's fixed with putty silicone. So the little device should be stable. And it also gives a neuromuscular relaxation to the joints and to the muscles. And now the patient is trying to get a little bit used to this. And we have also such millimeter scale papers, which you can use. And this is a very, very good documentation, say before and after the treatment. So when you, for example, make a splint after the treatment, you can see if your splint has any effect. So here we can say register the motion or the movement of the patient, and we keep this as our documentation. Now this is with spray. The patient has to get a little bit used to this, but it's in after 5 minutes, so it's very simple and very easy to manage for the patient. Now we take also this impression with our white wax plates. This is our first bite registration. So of course we will reduce the vertical dimensions a little bit later. And this is also an animation which shows you this. So this is our wax plate again. So we move this into the centric position. And here's our registration plate to mount the models in the correct centric relation position in our articulator. It's simple to use tool. Here are the wax plates, and we can trim them down to get more, say, reduce the vertical dimensions a little bit. And this is a very important picture here. So we see here is your centric position. Somewhere this is in this area here, we have possible, say, habitual ICP, habitual maximum intercuspation positions. Here you see lateral right, lateral left, and the protrusion. So this little thing is exactly taking a record of our mandible movements. And when we're going to adjust an articulator, so we see the centric relation here, and we see the adapted position. And you see, especially here, you see in CR, in centric relation, this patient has a significant interference here, and this is his adapted position. And then you can consider grinding this off, doing extraction or doing intrusion, but you get two different positions, which can be very helpful for the further treatments. I think a question we always hear, oh, mini-rec is open the bite too much. But you see here we have a distance of 9 millimeter, which is okay. And this is a statement of Dr. Oclusense that if, as long as the condyles are in CR, in rotation, also higher distances of 20 to 25 millimeters are possible. If we have a translation, then I agree this distance is too high, but in CR, if we have a rotation in the condyles, this is okay. And this animation is showing you again, so our jig and our bite registration. And also here we can consider movement. And if we have a high spot or an interfering contact in our, say, centric or in CR position, we can grind or take this contact off if necessary. And you see here also with the bite registration, also when we're going to, if we want to change the occlusal surface, we make a preparation to take all teeth down to make a new restoration, or waxing up, for example. But we have fixed the right position for our patient with mini-rec, so we can use this reference positions anytime. This is also a good position if you do occlusal splints. I would also recommend to use this tool when you do occlusal splints to give the patient a new occlusal surface by a splint. This is a very good tool to put it in the right position of the mandible. Of course, we can also use other tools. Neuromuscular relaxation is very important. And we have two tools for this, aqualizer or rehabite. And sometimes this can be our first aid kit. So Aqualizer is a self-balancing splint. It's ready-made, it's filled with water, and this tool can help to compensate interfering occlusal positions because it's hydrostatic. So it's like a waterbed, it's automatically balancing your mandible into the right position. And is a good pain reliever for those patients who have stress or strain in the muscles, helps you immediately. And interfering high spots automatically will be balanced. And the mandible is moved into a physiologic position. And the patient tells you, I'm okay. And this position can be a good position for a bite registration, of course, again. And then you have exactly a neuromuscular position of the mandible. Again, here, interfering contact, adaptation, and with the Aqualizer, we can take out this interfering information and move the condyles into a good position. And finally, when we have this position, just inject some registration material between the anterior teeth with the Aqualizer still in place. And then we have a good balanced, a good bite registration exactly in your neuromuscular position. It's a one technique, and which is very useful on some patients. Rehabite is a new tool, and this is, we could say, also like an Aqualizer, but this is mostly a physiotherapeutic training device. And this training device can help us to get better coordination of the muscles. And the patient's biting on these two pads, bite pads, they are filled with a liquid. He keeps a position of 10 seconds. You have a haptic control on your fingertip. Then you open the mouth as much as you can and you stretch the muscles. On this exercise, you repeat 10 times. And because when we do it 10 times, it helps, and we make a little break, 30 seconds, and another 10, and another 10 times. So this is a typical physiotherapeutic training, which gives a very, very good coordination to the muscles. And this can be very helpful also for patients during orthodontic treatments, because patients with orthodontic treatment, you cannot make a splint. And this is a really breakthrough in CMD or TMD therapy if the patient wants to be active. And this is nothing new. 30 years ago, there was a German professor, and he already made some clinical researches on those, say, physiotherapeutic and manual therapy. And he realized it is very, very effective on patients. And it's a trainer. And this has been also evidence-based clinical proven from the University in Düsseldorf here in Germany. And in some cases, this was the conclusion of this research. Rehabite can substitute, in some cases, a dental splint. And this is very interesting for those patients with orthodontic treatment, because they cannot use a splint, but they can use a tool like this to get rid of the pain. Yeah, this was a little teaser in different say, tools of diagnostics and treatments and pain treatments. And finally, occlusion. And we have two positions, static occlusion and dynamic occlusion. And why is occlusion so important? Because occlusion is almost involved in every process we do in dentistry: orthodontic treatment, preservative treatment, diagnostic, prosthetic care, functional diagnostic. So occlusion is always, it's omnipresent. And when we check the occlusion, we should check different movement, because the mandible can move in 4 directions. So of course we have to check the static occlusion. We have to check the protrusion, we have to check the lateral intrusion right and the lateral intrusion left. And of course, we want to look for those interfering contacts, high spots, which probably provoke an adaptation, and how we can find or exactly locate these interfering contacts. And for this, we have a lot of tools, and of course, we have to get rid of these contacts. And I know that most of the dentists like to grind and say, oh, this crown is too high. But yeah, how can I take it off? A grinding dentist. But this is not the way we want to adjust occlusion. So we want to be more, say, specific, more detailed. And we want to check different positions. For example, class 1 canine guidance. This is a good situation. Huh? But we have also class 2 canine guidance. Can happen. We have class 1, a group function, which is okay. Yeah? Class 2 group function. So there are different positions. Now there's a question, what should I use? Well, can I grind? Can I not grind? Probably I need more research. Subtractive, I'm going to equilibrate to grind it down. Maybe orthodontic treatment is a tool which I can use. I can probably use a splint first. And I can use a tool called additive dentistry. So I can put maybe some composite to change the occlusion. And this is maybe helping the patients better than instead of grinding. So we see additive occlusal adjustments. Selective equilibration means I have to consider really, really carefully how to grind, where to grind. Usually we say the green areas, this area. This is no problem, you can take this off. The yellow is a little bit more complex. And the red area, you have to really consider it's necessary, yes or no. When you reduce the cusp here, you probably reduce the vertical dimensions, which can cause another problem. And of course, Bausch is offering a wide, say, selection of different articulating test materials. There's also a question, what should I use? There's so many print materials, I'm confused. We have all kinds of colors. We start from 200 microns down to 8 microns, different materials. And now I give you a little bit overview of what is necessary and what not. And of course, the thick paper, this was the first product my father invented in 1953, is still state of the art. Yes, people say, oh, it's too thick. But if you can read this information, if you know how to use it, it's not. It gives you a good information about occlusion. It's a thick paper, 200 microns, but it's full with color. It marks on the wet surface with saliva, on wet ceramic surfaces. So we put some special adhesives into the formulation that it sticks, the color sticks on the wet surface. And it gives big, massive markings. Okay, but when we can read the markings, there's a good advantage. We see here, we have areas of very low pressures, but you also have areas of very high pressure. With the Oclusense, with the digital machine, we can have the same information, but here we see it very clear on the occlusal surface. And if we take a close look at this particular spot here, this is the contact. And this is not, and only the green area. This is your occlusal contact. And this is an animation here showing you the intensity of markings. So if we have, say, a contact, not a contact, but we touch the paper, it gives a mark. Very, very, a very low mark. If you have a higher pressure, the marking looks like this, and the real contact looks like this. And here, if you see contacts like this is a real contact. And this material is available in many different varieties and colors. And I just show you a little movie from a dentist, Dr. Frank. He is a good dentist in Germany, and he has the best camera to do intraoral movies. This shows you just an example how to use it in the mouth and do occlusal equilibrations. And you see, we do not need to dry the teeth. We just go in on the wet teeth, on the wet surfaces. So we see one big, massive contact here, which can be equilibrated. So he takes a very fine football-shaped diamond for the first contact. And then we check again if we have a better distribution of the contacts. And for ceramic, we recommend very fine polisher. And also for the final polishing, where he recommends to use a 3 microns diamond polishing paste. This is just fine tuning. And we can see here, okay, again, we are checking, and you see we have a good distribution. So we have 2 contacts. Here we see a little initial contact. And only do minimum adjustments because we work on the very safe ceramic surface, and the new ceramic surfaces, they have very, very thin layers. So we cannot take them all off. So then you will destroy the work of the dental technician. Now you have to do it a couple of times until you see a good distribution that all contacts are very, very equal. And of course, always ask the patients, do you feel that there's an eye spot? And also here, we check the dynamic movements. And finally, the fine tuning with the polishing paste. And of course, we have also paper of 100 microns. We have papers of 40 microns. There, 40 microns much more thinner. And also, as we see here, it's a fine control. We recommend this kind of papers for all kinds of ceramic restorations, composite restorations. And then the markings are much, much more precise. And of course, we check always both sides together or step by step. And also here we check if we have enough ABC contacts. Then we check the dynamic occlusion again with a different color. So we can see exactly how, if we have a good canine guidance occlusion situation. And also you can see how many, which area is touched by our guidance, so which anterior teeth are guiding. And to check dynamic movement is very, very important. So you see it later because dynamic movements can cause significant problems if you have any interfering in the dynamic occlusion, especially in the movements. Also, protrusion movements. Here we check the anterior guidance. Yeah, and what we have seen, this looks okay. Finally, for the final adjustment, we need some very thin materials, of course. We have it in 8 or 12 microns, so there's not a big difference. And of course, here we check again the movements of, say, static, maybe in red, the dynamic movements in a different color, for example, blue or black or green. And then we get a very, very clear image of the occlusal habits of our patients. So we can see if we have interfering contacts in the working or a non-working side. So we can check if he has a good occlusal balance, yes or no. And the same we also do with the digital occlusion. This is the same procedure. And here again, I show another movie on the real patient. So with 8 microns foil. And of course, we have also different colors, black and red on one side and the other side. And I just show you a restoration sample. So here we see a defect on the patient. So, and this is a case from my good friend, Professor Sanata. And first we use the BK51. This is 100 microns paper in blue. And we have to check the margin of the tooth preparation and the occlusal contacts. So what does it mean? The margin is that we have to know some basic information about the occlusal anatomy. So this is our things we have to consider. That is the outer, the inner ridges, the grooves, the surfaces, the inner inclines, and so on. And when we do a wax up, this is a very good training to get more or to get a better experience with occlusal morphology. And this is a course which Dr. Tininia Gomez is teaching sometimes for us. And diagnostic waxing is very, very important to have a better understanding about occlusal surfaces. And especially when we have a situation like this, so we see here occlusal interference, a massive C contact. We can adjust a little bit to have better directions of the occlusal forces. But still we have a high spot. And we recommend in such cases also to use a mixture of 2 materials. First, take a paper, 100 or 200 microns paper, and do a combination with a red foil. For example, a 12 microns metallic foil or 8 microns red foil. You get a much, much, much better visibility also on wet surfaces. And we call it a 2-step method. And sometimes the use of ceramic materials are really, really hard to see. So this is a very good technique to have more visibility. You're much safer. You have not overseen. You have seen the right contact. And this is the way how it looks on the real teeth. You see here is a big, massive, massive high spot. And here we see the other areas. And this was after the treatment. And finally, now we go forward into the digital occlusion. I see is a one question here. So this is our new digital occlusal technique, Oclusense. Oclusense has been developed from Bausch in a period of almost 7 years. This is a disposable sensor with a red color coating on each side. And this sensor is connected by a Wi-Fi with an iPad, and only with an iPad. And it gives you also the information about the different input of forces on occlusal contacts. And it gives you also some information about the shape of the occlusal contacts. And you have a database in this software, and you can recharge at any time like a toothbrush. So it's a very handy, say, design, ergonomic design. And because it's a mobile device, you can also, if you use it in a clinic, you can take it around to many areas in your place. The Oclusense sensor is a 60 micron thin color-coated foil, and we have about 1018 pressure-sensitive pixels. And the software can display 256 levels of pressure or forces. And because it's a color marking sensor, it's like a regular articulating paper, we have a combination of both. And see, there's another animation here. These are the real contacts, these are the Oclusense contacts. So you see these are matching. And because this is individual from patient to patient, the color markings are very helpful to identify the real areas. Now, some other systems, yes, there's another system called T-Scan on the market. They do not have a color marking. So this is a little bit complex or not as easy to find the right, say, contacts instantly. And here I show you a very interesting movie. This is a CAD-CAM restoration. So we have a patient here with 20 CAD-CAM made IMAX crowns. And very nice work also from Dr. Frank. And finally, we start. First, we recommend to dry the occlusal surface, especially if you work with IMAX ceramic material, because this is a very hard to see material. When we put the sensor into the mouth of the patient, we give the patient a little bit time to get used to this tool. So when the patient is okay, he is adjusted now the timeline to 4 seconds. So the patient is biting on this tool, and the record is now downloaded into your iPad. And then you can compare with your record in the iPad and with the real contacts you see on the surface. Here, here, and here. When you start adjusting the occlusion, also here again, it's a fine tuning. Take a very fine diamond, no? And ask the patient always, do you feel the contact, yes or no? And the goal is to have a good balance on each side, that they have a good balance occlusion from side to side. We also check here again the lateral occlusion movements. And then here again, we check the movements with the Oclusense. So the Oclusense can be also used for checking the movements, lateral protrusion left and right, and protrusion of a course. And you can adjust the timeline as you wish. So you can from 10 seconds to up to 60 seconds. And also here we see a little contact between 4/6, 4/7. And always check for so-called video occlusion contacts, or say contacts on the non-working side, or we call this contacts hyperbalances, because they can cause a big problem for the patient and afterwards. So when the patient tells you, I feel okay, it feels good, you also hear the sound when the patient is shutting the mouth. If it's all the sound is equal, then you have a good balance occlusion. Yeah, as you can see, the Oclusense gives you a good information, and it's also a good marking tool, even on those hard to see surfaces like IMCS. Especially when equilibrating a bigger reconstruction like this, it can be very, very helpful. And also again here, fine tuning with a very fine diamond paste. But you can easily see if the forces are balanced or not balanced, how the patient is moving the mandible. Do I have some interfering, say, contacts on the non-working side? What kind of information I get out of this screen from the Oclusense? So this is a big question. And you see here, we have a lot of red, we have yellow. You see here, we also have this distribution of forces. So this is, I would say, an equally balanced light. So we have, it's okay. Huh? Again, here we see, we start with some checking. So we have one initial contact, then the patient is biting into his maximally intercuspation, then it's moving to left, to right. So you see all these columns coming up and down. And Oclusense makes a record. This is a quick time movie. You can say, look at the movie anytime you want. You can stop the movie. You can check where's my initial contact. What is the timeline of this movie? And here we see some examples. So we see here, we have a maximum occlusion. So it's almost equally balanced. Here we ask the patients, a lateral occlusion, move to the right, and you see a massive contact on the non-working side here, a massive contact. This can give you a problem. And when the patient is moving finally into its end position, it disappeared, but this here can cause a problem. Of course, we look again, equal distribution of forces. And here again, lateral occlusion movement, here again, and also we see here massive contacts on the non-working side. And position. Now, we can compare, you see this is matching here. Protrusion. And when you take a close look, so this is an image of this patient, you see 4/7, yeah, and here a significant contact here, 4/5, 4/6 is here. But this area is more flat, so and the force is a little bit reduced. 4/4 here, 3/6, big contact here, here. And also you see here lower forces. We can also see what is the input of forces on my posterior teeth. And this is the next step. What does the colors tell us? So does red color means grind off? No. Imagine you standing on a nail board and the nails are all having a different height. And you see this image. So this is my nails. So we have a column which is very high. This is maximum force. But we have the red color means we have a delta from here to here. So the delta means the occlusal surface here is very sharp. We only have one contact, one significant contact. But this can be also lower. So the delta T is always the same. This is relative to the surrounding areas around each other. So you can also have red columns with the same delta T, but with a lower impact of forces, and so on, and so on. So red is a sign that this occlusal contact is very small. It's a very tiny contact. Orange means this contact is a little bit more, it's bigger, the area, the diameter. Yellow, it's also, the contact is getting bigger, and green is a more flat contact. Green is a typical sign for patients who like to clench or grind. Bruxers, we have bruxers, the green column is up here, but the whole surface is green. That means they have a flat abraded surface. And you can easily see you are a bruxer, or maybe your restoration is flat. Again, here we see small contact areas. And here, this you see, this is more flat. This area is more flat, has no force. But you see, this is maybe has been equilibrated by the patient himself or by the doctor or whoever. Also here we see contacts, they are more flat. How to adjust the machine? So you have many different possibilities. No? Usually we recommend to adjust a timeline if you do different testing or different directions between 10 and 12 seconds. The record mode means 50 Hertz, means you get 50 images a second. And you can choose between a 3-dimensional and a 3-dimensional view. Usually we say the patient should be in an upright position. For the first initial checkup, we should not try to deprogram his muscles because we want to see his habits. This is a little overview what you can adjust. So we have to enter, of course, in the software a patient name. It's a small database. We have two sizes of the sensor. We have say a regular size and a bigger size sensor. We can choose between the record mode. Of course, the patient has to be set active, then the name is showing up in the display. And we have a live mode. So this you see the occlusal context automatically or instantly on the screen. And then on the record mode, the machine is only recording the contacts. So they have many possibilities to set up this software. Occlusal positions. So usually we recommend, we tell the patients, we start from open mouth to ICP. So the first contact will say activate the sensor. And here we look for significant anterior contacts, and we check the balance between left and right. And we also check for non-occlusal areas. So this looks like this. Here's my first contact. Then we go into the ICP. This is my ICP position. So it looks okay. So the next position is from ICP, we are going to the left lateral protrusion. So we want to go from ICP to left, and then we're looking for significant guiding teeth through the whole movement, and we're not only focusing to the end positions. We want to see what is happening in between. And this is the big advantage of Oclusense, that we can see movements we have never seen, or let's say documented before. And again, from ICP, we move to the lateral intrusion left, and we have something like this here in between. You see here, here's my direction. So we have a big kind of group guidance here, but we also monitor here, oh, on the non-working side, we have a massive contact on the non-working side, a hyperbalance in between. And when we move again and more, yeah, this is my end position. My end position looks okay, but the movement in between looks not okay. And same we do to the right position, lateral intrusion right, ICP, we move to the right. Yeah, also here, it looks okay. And here's my end position, a group guidance. So what we see is a different, because the sensor is very, very sensitive, we see different positions in the moving. And what is the concern about this information? So we have one patient case here from one of our speakers, Dr. Magdalena Okrut from Poland, and she is also using the Oclusense for more than 3 years. And this was one of your patients, no pain, and this was his ICP. This looks okay. Yeah. But what we see here, we have a big, we call it non-carious cervical lesions here on 3.6 and 3.4. And what is the reason for this? Because we have a different input of forces on this area. You can see it here and here. And the thing is, we have to consider, is this a straight movement, or is it a kind of, you remember, adaptation, we're moving like this, and we touch some areas between our moving before we come to point B. But we create a contact here, we create a force here, create a force here. So this can happen. And what input of forces we do have during this movements. And this is, I see, a new theory I just invented with Magda. And this was also research from a Brazilian dentist with finite elements. So vertical loads is okay, but if we have lateral overloads like here, so we have a tension here, can this be a reason for those cervical lesions? And we have to, and the Oclusense is a good tool to find together, see a diagnosis if this can happen. Yes, we see it. And see, if we have a massive input of force during these lateral intrusion, during the dynamic occlusion, yeah, probably it can happen that this little area here will not be stable or can crack during the time. And we have a lot of those patients with power functions suffering from these, say, NCCL problems or non-carious cervical lesions. And also here again, especially when you do implants, this can be very destructive to an implant. Another case for Professor Tanata. No? First appointment, no muscle pain. He's clenching teeth during the night. Occlusion clinical analysis is necessary, and a splint is probably necessary. And right lateral movement with work and non-working occlusion contacts. Left lateral movement with non-working and non-working occlusion contacts, and anterior teeth, protrusive movement with some posterior occlusion contacts. And we gave him a mini rec to find his CR position. So here, right lateral movement, you see here, a group guidance on the right side and massive contacts on the non-working side. Same to the left. a big group guidance to the left side, massive contacts on the non-working side. Protrusion, contacts anterior, okay, contacts on the posteriority. So this man has no real occlusion, which can cause a problem. We give him a mini rec, put him in CR position. This is my initial contact in CR. We can also measure this or check this with the Oclusense. And then we make him a splint, an occlusal splint in CR. And also here we can check for adjusting the splint. We also recommend the Oclusense also as a documentation to see what we have adjusted and how's the patient's reaction. And here we can also see the splint after adjustment, further adjustment, and now the splint is in the mouth, and again, maximum intercuspation on the splint. This looks very balanced. Movement to the right, a perfect canine teeth guided or simulated canine teeth guided occlusion. And to the left, we have the same thing. And for adjusting splints, we also have a, say, a red color, which can be painted on a hard occlusal surface splint. And this is a splint we have been doing on the patient. And we see, because the color shows exactly the areas or the parts of penetration. And also here again, we check with the Oclusense on a splint. On it needs more equilibration. We also cross-check with articulating paper. And on the splints, you can do easily occlusal adjustment. So this is, I say a good tool to simulate different positions. And finally, we are approaching to a better occlusal balance. We cross-check this again with the Oclusense. You see it's getting more and more balanced after adjustments. And also here we check lateral protrusion right. Yeah. You see good balance occlusion, equal markings on each side. Also again, here we check lateral protrusion left. And always as the patient was happy with the splint, so it fits perfect. So the patient was very, very happy. And this you also can verify with the Oclusense, that you have a good balance, distributed equal forces on each area, and a good anterior guidance. Another patient's case from Professor Sanata. So there was a patient who has received orthodontic treatment, and we have been doing an occlusion analysis. So we have before selective grinding, and we have been comparing it with his cast models. And you see here a massive, say, contact in centric relation position versus occlusal contact. Here. This was the verification with the Oclusense of this contact. Then we checked the lateral protrusion to the right side. So this looks okay. And verification with the Oclusense. Then we check the lateral protrusion to the left, and we see a contact between 1,3 and 4,4, and we have a contact between 2,3 and 3,4 here. And this is not okay. And this is what the verification with the Oclusense of this position. And Dr. Sanata, he removed all these, say, interfering contact. And again, we checked again the occlusion after occlusion equilibration. Looks okay, so we have a good distribution, but the patient says the CR patient is okay, yeah, but you can verify with the Oclusense. The right lateral movement is okay, but the left movement has a problem. And the patient said the right movement is much more comfortable than the left side. And here we have a very good example. So not of, say, grinding anything down. So we can also restore the canine teeth or the guidance, the anterior guidance, with composite. And here we have Sanata, Professor Sanata has been putting some composite on a 233, and this looks okay. And now we have a good canine teeth guidance. So without, say, equilibration. So this is the additive restoration, additive technique, and also verified this position with the Oclusense. So we see also this patient has massive lesions here. And this could be, say, a result also of, say, movement of the mandible of adaptation process, which has a certain input of forces, which creates these lesions. And that is very important to restore, to avoid, to check these input of forces to avoid these positions. And here we see also the movement here. Here is, say, a non-working occlusal interference, a massive. Yeah, that's what can happen. And also here, big, massive lesions because of these, I call them hidden interferences. And therefore we need something that we have to restore the occlusal surface, and the waxing up sometimes, or the remodeling with composites is very important to avoid this. And because the X-shape form functions, they have to, say, consider the cusps and the grooves. So if you do a waxing up course, you get more familiar with the anatomy of the occlusal surface. And finally, we made a composite restorations here. And here now we have a good canine teeth guidance, verify with the Oclusense. Right side, good canine teeth guidance, verify with the Oclusense. So you see, we have a nice tool to verify different, say, techniques, different possibilities, how to do corrections. Additive is a good tool, splint is a good tool, research is important, subtractive dentist sometimes necessary, or orthodontic treatment. So, but everything what you see here is involved with occlusion somehow. And this is a book which has been published by two friends of mine. So this is, for those of you who are not this familiar with occlusal treatment, this is a book we sell at Bausch, a very easy to understand, easy to read book. You can also buy very complex, hard to understand books, but this is something I can really recommend if you're going or get more experience or knowledge about occlusal adjustments. Yeah, this is a saying of a very, say, famous philosopher. If you do not know what you're looking for, you will not understand what you find. And finally, I thank you very, very much for your attention. And now, yeah, I'm open to questions. Thank you.
Thank you so much, sir. It has been a great presentation from your side. And we're looking forward to questions from our expert panel as well as from our audiences.
Yes, please.
There has been a question in the chat box regarding the basic question which every Indian asks is what is the price of Oclusense in India?
The price of Oclusense in India, I think because we do not the prices for our suppliers, so we have 3 suppliers. I think they sell it around 1,400, 1,500 euro. Yeah, more or less.
1,000 euro.
No, more. In Europe, it's 1,000 euro. In Europe, now without tax. So with tax here in Germany, it's 1,300, including the sales tax. No? In India, it's probably a little bit more because we have to add shipping. It's probably 1,500 euro, no? Which is, I don't know, the exchange rate to rupee. No? So it's much cheaper than T-scan. So T-scan you pay much more. No?
So regarding the sensor sleeve we have with Oclusense, is it can be used in one particular patient the whole sleeve, or is it the chances that we can reuse it? The question which is somebody asked, that the sleeve which is used for the Oclusense for a particular patient, is it the same sleeve can be kept for the patient and reused after a couple of appointments, or has to be discarded?
Yeah, so of course, the sensors are individual for each patient. So, but you can use the same sensor on one patient, not on 2 different patients. Sorry, yeah, on one patient a couple of times.
Oh, so in one same patient, can it be used after in multiple appointments? Will the sensitivity of the sensor reduce, or may hamper, or need to be?
It's good for about 20-30 uses.
Okay, sir.
Yeah.
Yeah.
Peter, what about the applications in the removable partial dentures? For example, a cast partial denture, we have natural teeth as well as removable teeth. So how will this device work in a case like a cast partial denture?
What do you mean with a partial denture? I didn't.
Yeah, with partial. Yeah, with partial dentures, right? With a partial.
Yes, of course.
Because I think the articulating papers we use for natural teeth are quite different than the one which we use for removable teeth. So probably there's a difference in the intensity of contacts. So does it matter in this case?
Yeah. No. You can use it on any cases. Huh? Yeah. Any case is fine because the sensor is very sensitive. Huh? There's also a little bit difference because T-scan, when you want to activate a T-scan sensor, you have first to take a very hard bite on this T-scan sensor. Huh? Oclusense is a different technology. So here we do not want to work with these, say, high forces because nobody's biting with high forces unless he's a Bruxer. Yeah.
Okay.
And you remember my first, in just the beginning, I have shown you an animation about the periodontal ligaments. Right. If you bite hard, you have an intrusion of the teeth into the periodontal ligament. So this we have to consider. A natural teeth, we have a big intrusion between 10 and 20, some say even up to 100 microns.
Yeah, but given the nature of contacts, like you said, the thickness of the sensor is 60 microns, and we usually crown and bridge in the natural teeth, we go for something less than 40 microns, and for denture, something more than 100 microns. So how does the sensor?
I didn't get it. Sound is I didn't hear it because your sound is changing. Can you repeat it, please?
I just said that the thickness of the sensor is 60 microns.
Yeah. It's 60 microns.
And when we do 60 microns, when we do the adjustments for the ceramic teeth and the natural teeth, we require something less than 40 microns.
Yeah.
And for denture teeth or for...
No, it doesn't matter. It doesn't matter. Even with 200 microns, you see the same markings. It doesn't matter. It doesn't matter. This is the old way of thinking because this is the old, everybody in the old days said, oh, 8 microns is still too thick. If you compare the contacts with 8, with 200, 100, 8, 40, the markings are always the same. Yeah. So we checked with different materials, we see no difference in the markings. The markings from, say, bigger papers get more massive, more heavy. But if you take a close look at those markings, the point of the input of forces is exactly the same.
Okay. Is this all real time? For example, if the patient is doing some movement, are you tracking it in real time, or we have to wait for the data to be collected?
This is real.
And then
this is real-time tracking. We do have an, I say, in a few weeks, we will have an update version of the software. So then we have an adjustment. You can adjust the speed of the animation. You can just make it slower, or you make it real time, or whatever you want to see. No? Maybe for diagnosis, it's also better to have a lower speed. You can see what I told you before, that we see these moving patterns, and that we see this touching of contacts on the non-working side, which will disappear in the end position.
Okay.
Which can be our reason for these non-cervical lesions.
Right. We have a question from Dr. Krishna Chaitanya. She's asking that if we have the articulating papers of all thickness necessary for the case, still do we need Oclusense?
Yeah, definitely, I think so.
Yeah, but see, in the past, we also did good occlusal equilibration just with paper. No? Yeah. So, of course, from my perspective of the selling this product, I say, yes, of course, you need an Oclusense. From a perspective of a dentist, I would say it's nice to have, yeah, if you have a tool like this. But if you're an experienced dentist, you can also do, yeah, you get the same results with occlusion test materials, paper or foil. Not the same, but the thing is the movements we are missing. Huh?
I would like you to highlight on the compatibility of Oclusense with the software of whether it's compatible with Apple or Android softwares. You know, is it only compatible with MacBook, or you know, it's open to all the software?
Currently, the Oclusense is only working with the Apple iPad, yeah? And this has a specific reason, because Apple iPad is the firmware is always the same. No? That makes it much easier for us also for software updates. No? And we are working now on a new project that we will say transfer this information, which we get from the iPad, say simultaneously also to another software on, say, any Windows computer. No? But this is in the future, not yet. So now it's only say it's only say available for the iPad machines.
Okay.
I have a question. Can we use this newly advanced Oclusense to know how much height of the tooth or the high point we can reduce? Does it tell us how much amount of structure?
No, definitely not. Definitely not. So this is what we have to consider. Yeah, this definitely reduce. Yeah, this is definitely not. So if you want to approach the maximum, to reduce the high spots, as you have seen in the videos from Dr. Frank, you just do a very, very fine approach with a very fine instrument, very fine diamond. No? Yeah. Instead of taking it off, and especially when we speak about new CAD/CAM ceramic restorations, no? Yeah, this is very sensitive. You cannot grind it all off, and that's also the reason I recommended before we go into occlusal grinding. Yeah, we have to do all the things with a Facebook, with an articulator. Usually, we should not grind. So the best thing is no grinding, just it fits. Yeah, this would be perfect. No? So usually we want to avoid grinding. That means we have to do all the necessary preparations before. It means a good impression, no? Digital or silicone impression, a good setup in an articulator. We can simulate the occlusion in an articulator. When we use a full adjustable, it's even better, a faceable. So we should avoid grinding. So usually the occlusion should be perfect from the beginning.
Thank you, sir.
Yeah.
Thank you.
If Occlusense can tell the amount of reduction we have to do, then I think Dentists are not required. Anybody can do that.
Good one, Dr. Sanket.
Well, overall, you need a good understanding of occlusion, and that's also recommended to consider taking a course, maybe about occlusion morphology, waxing up courses. They help you very much to understand how the occlusal surface should be designed, or when you do composite restorations. And with composite, you have a great tool. If you've seen additive occlusal restorations can be very effective on natural teeth.
Thank you so much, sir. Any other questions from any audience or expert panel? So, Sanket sir, can we share the certificates?
No, I think there's a question in the chat box which states, can you reshare your choices of articulating papers for porcelain fused to metal and for all ceramic? And also they have asked for the flowchart slide.
What do you mean, a flowchart slide?
I think so. One slide you have shown. Maybe they want to re-see it, or maybe sir, you can just answer this, sir. Like you can, yes, sir.
Of course, we recommend you should at least use three materials: a thick paper, a thin paper, and a foil. So three thicknesses. No? Thick papers have the advantage; they give good visible markings in the wet surfaces, no? And they also mark what we call progressive. But I explained to you how to use the 200 microns. So, but my father was the inventor of this technique, and it already showed some pressure forces. You can see by the thick papers. It's not like an Oclusense, but you see a difference between light or say a regular and really high spots. And the medium paper 40 microns in between, and for the final adjustment 8 or 12 microns or a combination of both.
I think what we really lack is we see a lot of literature with equilibration in journals and books, but unfortunately there is less amount of articles or topics written in books on this particular part of papers.
You mean for the Oclusense?
Not Oclusense, in general on the articulating papers, the sequence, the design, and the selection of articulating papers. Most of the prosthodontic literature will have so much of discussion on what kind of occlusion, the occlusal contacts, the reduction criteria, but I think we lack the proper guidelines in terms of the selection of paper and the circumstance in which it can be used. Probably that is where there's less of clarity. It's like an articulator. We have an articulator, and you only depend on the guidelines given by the book, and there is less of literature in the journals and maybe in the books. So it is like passing on from one generation to the next.
I agree. So I agree with you totally, because the problem is occlusion, even in Germany and other big universities in Germany. In the 80s and 90s, occlusion was a big topic. Nowadays, occlusion, you get as a student, they teach you 2 hours of occlusion. Fine. That's it.
Right.
Yeah? And say goodbye. You're a dentist.
Right.
we had a course in Poland, I think 3 years ago, and was a friend of mine from SIM Articulators. And we had a lot of very nice young Polish ladies, dentists, just graduated from university, and it was the first time they had a face bore in their hands.
Right.
First time, and they have no idea how to use it. Yeah. So all these, education, you can get this education, but you have to visit courses. Yeah?
True.
And in Germany, we do have some courses, but they are privately based and they're not very cheap. So if you want to be an expert in functional diagnostic, now this is an investment of around 30,000 euro for education.
Right. But I think it is more of a confusion. There are different schools of thoughts, different academies proposing different schemes. And I think the universality is missing. And I think that is where people get confused,
Yeah,
And,
I agree 100%. That's the reason.
I have my friends in Panky who talk about different things. Some friends in Dawson Academy, they say
They have different things.
And, yeah, there is a Brazilian guy who says different things. I think there's a lot of difference of opinion in what they perceive and talk about occlusion. And they have the philosophies of doing their cases. So probably.
Yep. And there are only a few people who really talk about occlusion and understand occlusion, and all the others say, oh, my dental technician is taking care of it. No? Yeah, that's a problem.
I think Dr. Prafula has a question, I think.
Yeah, please.
Thank you, Dr. Shigli. Good evening, Peter. It was an amazing presentation.
Thank you.
Yeah, for my academic interest, I'm asking, do we have any published articles on reliability and accuracy of the Oclusense?
Yeah, there are a few. So for the Oclusense, we recently have some articles, and Occlusion. Yeah, there are some articles have been published in some German magazines, but not how to equilibrate occlusion. So this is something, yeah, which is not treated very well in the literature. So you learn a lot about implants and other things in aesthetic dentistry, but occlusion, hard to find. We still have some articles, and we still have some books here in Germany which take care of this topic, but it's not all over. Maybe some books, of course, United States, Dawson Academy, so they have some books and publications about this.
Yeah, thanks for that input. Wish you share them with our IPS, for members of the IPS. Also, yeah. I would like to know, can we measure force thickness time with occlusions?
What do you mean? The force? The force cannot be measured. So we just give an idea about forces, but we do not measure in an SI unit like Newton or as anything else, no?
I have been using Bausch articulating papers from last 34 years now.
Yeah, thank you.
But I don't see any difference between your beautiful articulating paper and Oclusense.
No, if you're used to articulating paper, yes, I agree. Yeah, it's the same. We talk about the same context. Huh? The only thing is you see this, these dynamics, these lateral intrusion movements. You see this context which show up in between them. And you always have a good documentation. So this is a record of the occlusion of your patients. You always keep a record.
Thank you.
So one of the participants is asking, which book do you suggest
the chat box?
Sorry, again, please.
So one of our doctors is asking, which book do you recommend for reading?
Yeah, first of all, I recommend the book. So this is a book here called Occlusion Made Easy. I just maybe just share my screen again, just a moment. So this is a book. So this book has been published from two French professors. One is Professor Gérard Duminil, and the other one is Professor Oliver Laplanche. Both professors are teaching occlusion in the University of Nice. This is south of France. And I know Gérard for many, many years, and he's a great dentist, and he's really specialized. The idea of them was to make a book which is easy to understand. Yeah, you can buy yourself a book from Pete Dawson, but you have to read it 3 times to understand it. Yeah. And also the problem is, in the United States and in Europe, we use different expressions for the same thing. Né? So we mean centric relation means something different than centric relation means in the United States or in Brazil. It's also a little bit confusing. Somehow, this book is, I just give you some examples, occlusal adjustments. And this book is clearly showing how we can approach occlusal adjustments, what we have to consider. This is easy to understand. And this is available with our dealers in India, especially Liberal. They should have it on. They don't have it in stock, but they can order it for you. And then we have another book called. There's a book just been published. You've seen I have a lot of animations from the company BioArt. BioArt is a company from Brazil. They are the biggest manufacturers of articulators in the world. They make for a lot of other brands. They do the same thing but with another name. And they have been recently published also a book called Logical. And maybe we have also a little, let's say, PDF file, which I can maybe give in this group. Maybe I send it to Dr. Reddy or somebody else of this group. Maybe you can, if you have an email provider, you can download it and see. This is also some kind of occlusion, and this is also easy to understand. Very nice illustrated book. Yeah.
I think Dr. Jangalahari can probably.
Then I can maybe send it to one of you. No? Yeah.
Yes, Pete.
Thank you so much, sir. Now we would like to share the certificates.
Yeah. What do you mean the certificates?
So here we go.
This is, thank you very much. I get a digital certificate this time.
I think excellent presentation, Peter. It was wonderful to have us. Yeah.
Thank you so much for such a wonderful presentation. So the videos were really informative, and it simply opened our eyes for something very complicated, inward occlusion.
Yeah, it's hard to, very complicated, but with the right material, and I think my colleagues from Brazil, they have done an amazing job explaining this. And maybe I can send it to you or one of the group. I give you this article from the book Logical. It's very easy to understand, very nice illustration, makes understanding of Oclusense and occlusion generally much easier. No?
I hope there are many students today because it will benefit a lot to them. I hope they're there today. Excellent presentation.
Yeah, you're welcome. My pleasure, and it's a great honor for me to be part of this group. And of course, maybe one day you're very welcome to our new education center in Cologne, Germany. One day, hopefully.
Surely, we'd love to come.
Oh, thank you so much. Yeah.
Thank you.
And next, we have our certificates for our expert panel. First of all, Dr. Kamal Singhli.
Yeah.
Thank you, sir.
Next, Dr. Parmitesh Banga.
Thank you so much.
Next, Professor Dr. Santosh Singote.
Thank you so much.
And last but not the least, Professor Dr. Bijnish More.
Thank you, Dr. Jangala, Dr. Sanket, and the IPS Telangana team. Thank you so much for this opportunity. Thank you, and wishes for the upcoming events as well. Thank you so much.
And this one is for myself.
Thank you.
Good luck.
Thank you, Dr. for being a very good moderator. Yeah, I think we should.
Thank you, Peter, for your valuable time and sharing your knowledge with all our fraternity. Thank you very much.
Thank you. Yeah.
Thank you, Vijay. Thank you.
Thank you.
Thank you, Madam Kamal Singhli, Madam, and thank you,
It was a
Santosh.
pleasure.
Thank you very much.
Anytime for you.
Thank you, Arka. Thank you.
Thank you, sir.
You have
Thank
done
you
a
very
well
much
job.
for the
Thank you. Thank you.
Thank you all.
Good day, Peter.
Thank you.
Big hi from India.
Yeah. Best regards from Cologne, Germany.
Thank you, Peter.
Goodbye. Hope to see you soon.
Goodbye.
Take care. Bye bye.
See everybody tomorrow again.
Yeah.
Bye.
Definitely.